Okay, hello everyone, and welcome to the psychiatry component of your first mock paper on psychiatry, forensic medicine, and community medicine. Right, so as you all know, you'll be getting a combined paper of psychiatry, community medicine, and forensic medicine for your exams. Okay, and in that paper, you'll be getting uh, 17 true false MCQs from psychiatry and 15 single best answer questions. Right? So it's very important before the exam you practice with these combined papers rather than uh, practicing with separate papers, because it's very important you face the real exam scenario before going for the exam. Okay, so try to do those combined papers as much as possible before the exam. Okay, and then talking about this paper, uh, out of these three subjects, the questions you get from psychiatry uh, are pretty straightforward. Okay, so if you know the theory well and if you studied theory, you can score easily for the psychiatric component. Right? But things are a bit different when it comes to community medicine and forensic medicine, because sometimes you can get those tricky questions from those two components. Yeah, so it's very important you score at least 80% mark for psychiatry, because even if you get some difficult questions from the other two components, you can easily compensate. Because if you know theory well, and if you have studied theory, and if you have done enough papers, you can easily score more than 80% for your psychiatric component. Right? Okay. So with that in mind, let's continue with our discussion. Right. First about the true false questions. Right. Okay. First question. MMSC is a screening tool for dementia. Okay. What is MMSC? MMSC means the mini mental state examination. Mini mental state examination. Right. So this MMSC, it mainly tests your cognition. It's a questionnaire, a 30-point questionnaire, and at the end it gives you a total mark out of 30. Right? And remember, this MMSC has several components. It has scores for several components. For an example, it has around 10 questions, 10 points actually, for orientation. Orientation, around 10 points, right? Then registration. Registration, there are around 3 points for registration, right? Then attention and calculation. It gives you around 5 points. Okay. Then recall, mainly memory, 3 points. Then language, 8 points. Visual spatial skills, around just 1 point, right? So likewise, it has scores for these components, which are all part of this broad term cognition. Broad term cognition, right? Now remember, this MMSC is only a screening tool for dementia. A screening tool. Screening tool, and not a diagnostic tool. Not a diagnostic tool. Why? Because there are several other conditions which can give rise to uh, low score in MMSC, or in other terms, low cognition. So one is delirium, can give rise to low cognition. Then pseudodementia with depression, right? Then low education. Likewise, there are certain other conditions which can give rise to lower scores in the MMSE. So therefore, having a low score in MMSE is not diagnostic of dementia, right? It's diagnostic of only impairment in cognition, not dementia. That's very important. Okay? Right. So it's a screening tool for dementia. That is true. Only a screening tool or a diagnostic tool. Score below 20 is diagnostic of dementia. So I told you earlier, MMSC just a screening tool, not a diagnostic tool. Right. So what we generally say is if the score is more than 24, right, it is normal. If the score is more than 24, it is normal. So if the score is more than 24, it is normal, right? And if the score is less than 9, it indicates severe cognitive impairment. Severe cognitive impairment. That's how we generally interpret it. Right? So remember, it's never diagnostic. It's never diagnostic. So that is false. It's a component of the mental state examination. Right? Now, you should know the components of the mental state examination. Are the components of your mental state examination. Right? So I told you mnemonic in our theory sessions. Right? So can remember it as ASMT PCI. ASMT PCI, the components of the mental state examination. Right? Appearance, speech, mood, thoughts, perception, cognition, and insight. Right? So as you can see, cognition is a part of this mental state examination. Right? So there we can include MMSE under cognition part. So that is true. Score is affected by the level of education of the patient. Right? That's a problem we face when we are doing MMSE. Because there are some socio-cultural factors which can affect the score of MMSE. For example, this MMSE has certain components like reading, naming object, writing a sentence, right? So likewise, those are some components of MMSE, right? So if you have low education, uh, you have poor performance in those components. So the education matters, right? So if you have low education, you score low marks in the MMSC, right? So that is true. It is affected by the education level. Right. So what we can do is we have some other alternative examinations we can do to avoid this. For an example, MOCA. MOCA, right? MOCA is the assessment we can use in these patients with lower level of education, right? Right. Score can be lower in patients with severe depression. Right? So I mentioned this earlier. Right? So what is the condition in depression which gives rise to low cognition? That is what we call depressive pseudodementia. Right? So here it's not actually a form of dementia. There's no neuronal injury like dementia, but here the patient typically has poor effort, right? Poor effort. He use like I don't know type answers. He doesn't like to recall his memory. It's a part of this depressive spectrum, right? So the dementia. There also you get a low mark in MMSC because cognition is impaired. Right? That is also true. Okay. Next question. Regarding defense mechanisms. Right? Now, when you face a problem, uh, there are two mechanisms which come out. Right? One is this defense mechanisms. Defense mechanisms. Other one is coping mechanisms. Coping mechanisms. Okay. Now, what is the difference between defense mechanisms and coping mechanisms? Okay. So these defense mechanisms are basically, these are unconscious efforts. Unconscious. The patient is not aware. Right? Unconscious efforts to protect the patient from anxiety. Right? So defense mechanisms are unconscious efforts to protect from anxiety whenever the patient faces a problem. Right? Then coping mechanisms, they are basically the opposite. Conscious efforts to protect from anxiety. Okay, that is a basic difference between defense mechanisms and coping mechanisms. Right? So remember, these defense mechanisms and coping mechanisms can be either healthy or unhealthy, which are not good. So both type of these mechanisms are there. Right? Okay. So projection is when a person attributes their own unacknowledged feelings to someone else. Right? That is true. So for an example, a person with projection, what he does is he has those aggressive thoughts inside. Right? But what he does is he projects those aggressive thoughts to someone else. So he says that someone else is aggressive, someone else is hostile. Likewise, he projects his own aggressive thoughts to someone else. Right? So that's an unhealthy defense mechanism. Unhealthy defense mechanism. Okay. So that is true. They are always unhealthy. As I mentioned earlier, these defense mechanisms and also coping mechanisms can be either unhealthy or healthy. Right? So there are some uh, healthy defense mechanisms like sublimation. Right? Sublimation is a healthy defense mechanism. Likewise, there are both healthy and unhealthy mechanisms. Okay. So they are always unhealthy, should be taken as false. Sublimation involves channeling unacceptable impulses into social productive activities. That is true. That's a uh, that's one of these healthy defense mechanisms, right? So for an example, just imagine someone with aggressive, hostile impulses. Okay, now what he does is he takes up a sport like, for example, boxing, martial arts, right, to relieve those aggressive, hostile impulses. Right, so that's a good, healthy mechanism, coping mechanism, defense mechanism, right? So that is true. Channeling unacceptable impulses into social productive activities, sublimation. Okay. Right. Interjection is a mature mechanism where a person completely ignores outside criticism. Right? No, that is false. Right? So interjection means here a person adopts values or attributes of a person he loves. Right? For an example, here the person internalizes attributes of a teacher he loves. Right? So likewise, he takes up values or attributes of a person he loves. So those attributes and values can be either good or bad, depending on the person. Right? So person completely ignores outside criticism. That is false. This is taking up values of a person he respects. Okay. Reaction formation is when a person acts in the exact opposite way to their true feelings. That is true, right? So here, the person feels something but behaves in a complete opposite way. For example, just imagining a person who's having aggressive and hostile feelings, but he behaves excessively uh, kind and helpful outside, right? So behaves in a complete different way for his inner thoughts. That is reaction formation. Reaction formation. Okay, it's true. So it's very important you know the definitions of these various defense mechanisms and also coping mechanisms. Very important for your exams. Okay. This question. Hallucinations are misinterpretations of external stimuli. Right? What is hallucination? In hallucination, what happens is you perceive something, you feel something when there's no actual external stimulus. Right? There's no external stimulus in hallucination. To see something when it's actually not there. That's hallucination. Right? Then misinterpretation of external stimuli is what we call illusion. This is illusion, right? So there's actually an external stimulus, right? But you misinterpret it. Illusion. Right? So that is false. Not seen in depression. Now you know in depression, there's a component called depression with psychotic symptoms. Depression with psychotic symptoms. Okay. So what are these psychotic symptoms? Psychotic symptoms are delusions and hallucinations. Right. So in severe depression with psychotic symptoms, you can sometimes get hallucinations and illusions because there's altered perception. Right. So that is false. Seen in grief. That's true. Right. So we discussed this under grief as well. So in the early part of your grief cycle, you can get these transient hallucinations. Right. So sometimes you can see the dead person as hallucination. Right. But here, since the patient's insight is preserved, we don't call it pathological. It's just a transient hallucination, part of this normal grief cycle. Okay, so that is true. Not experienced by healthy adults. Right. So we discussed some types of hallucinations which can be seen by even healthy person. For an example, these hypnagogic hallucinations. Hypnagogic hallucinations and hypnopompic and hypnopompic hallucinations. So these are seen by even normal people. What is hypnagogic? Those hallucinations when you see when you are going to sleep. Going to sleep. Hypnopompic means when you are waking up from sleep. When you are waking up from sleep. So these can be seen by even healthy adults. Right? So that is false. Pathognomonic of schizophrenia. Right? You know, that is false, right? So diagnose schizophrenia, there's uh, separate diagnostic criteria, right? So in this diagnostic criteria, there are multiple components, right? So remember in these components, the first four components, right? So even one, if one of them is there, you can diagnose schizophrenia. What are those components? The first one is thought echo, thought insertion, thought withdrawal, or thought broadcasting. Thought echo, thought withdrawal, thought insertion, and thought broadcasting. The first one. Second one is the delusions of control, passivity, right? Delusional perceptions. Those are included in the second part. Delusions of control, passivity, delusional perception. Okay. Then third one is it's mainly third person or hallucinations. Third person or hallucinations. Then fourth one is bizarre delusions. Bizarre delusions. Bizarre delusions. Right? So even if only one of these four are there, we can diagnose schizophrenia if the person has fulfilled the relevant duration of symptoms of 1 month here, right? Of 1 month. Okay. So only these four are pathognomonic of schizophrenia, right? Just having hallucinations are not specific for schizophrenia, because there are some other conditions which can give rise to hallucinations. For example, delirium, substance use, mood disorders can also give rise to hallucinations, right? So hallucinations alone are not pathognomonic of schizophrenia. That is false, right? Okay. Next question. Schizophrenia, poor prognosis if the onset is in young age. Okay. Now you need to know that there are certain factors which predict poor outcome in schizophrenia, right? Poor outcome in schizophrenia. So there are some demographic factors. Demographic factors. There are some clinical features of schizophrenia which predict poor outcome. Then there are some other factors. Okay. So what are these demographic factors? Being a male, single. Okay. Then young age of onset. Then family history. If there's comorbid substance use. So these indicate poor outcome, right? The clinical features. If there's poor pre-morbid adjustment, right? If the onset is insidious onset, and if there's cognitive impairment, if there's absence of affective symptoms, and if there's poor insight. So all these indicate poor prognosis in schizophrenia. Then other features, if there are high expressed emotions in the family, if there's poor compliance. So it's a very frequently asked MCQ about these poor prognosis factors of schizophrenia, right? Okay. Poor prognosis if the onset is in young age. That's true. That's common for any of these psychiatric disorders. Okay. No evidence that there is genetic environment. That is false, right? So what they say is in schizophrenia, there's a genetic risk of around 80%. Around 80% genetic risk is there. And also there are some environmental factors which can contribute to this. Like for example, if there are obstetric complications like hypoxia, at birth. Then substance use, cannabis use especially, right? Then migration. So likewise, both these genetic factors and environmental factors can contribute to schizophrenia. Okay? Uh, That's false. There's evidence. Enlarged ventricles are seen in some, right? So when you do neuroimaging in a patient with schizophrenia, you can see certain changes, right? So one is this enlargement of the lateral ventricles, right? So because here you lose some brain tissue, right? So therefore, what happens is your ventricles get enlarged, right? So you can see that in the neuroimaging. It's a supportive feature of schizophrenia. Okay, that is true. Prognosis is better in developed countries, and that's false. What studies show is the prognosis is better in developing countries, right? In developing countries rather than developed countries. Why? Because in developing countries, there's a usually strong family support systems, right? And there's less social isolation compared to developed countries. Right? So therefore, you see better prognosis with most of the psychiatric disorders in developing countries. Okay, so that is false. Highly expressed emotions increase the risk of relapse. That's true. I mentioned earlier that's one of these poor prognosis factors as well. Right. So, for example, if the family environment, there's always criticism, there's always hostility. What happens is there's increased stress in these patients. So it leads to dysregulation of the neurotransmitters in your brain. So there's increased risk of relapse. Okay, that is true. Okay. Next question. Regarding bipolar disorders, commonly starts with depressive episode. Right, that's true. So most of these patients with bipolar, their first episode is depression. Right, first episode is depression, and later on they get manic episodes later on. Okay, it's true. Starts in the first half of life. Okay, now you need to know about this age of onset of these main psychiatric disorders. Okay, so in bipolar, the onset we consider is around 17 years. 17 years, the onset. Then depression, it's around 27 years. Okay. Then schizophrenia, it's a broader range. Schizophrenia, it's 15 to 54 years. So that's a broad range. Okay. So bipolar years, it starts in the first half of life, around 17 years. Okay, it's true. Characteristics of bipolar depression is different from that of unipolar depression. That can be taken as true. There are certain differentiating features between bipolar depression and unipolar depression. Okay, bipolar depression and unipolar depression. So, for an example, you take sleep. In unipolar depression, what you commonly get is insomnia, lack of sleep. But in bipolar, you commonly get hypersomnia. Okay. Then appetite. Appetite is usually decrease in unipolar and increase in bipolar. Bipolar. Then psychotic features. Psychotic features are also less common with unipolar depression, but more common with bipolar depression. Like us, there are certain differences between bipolar and unipolar depression. That is true. Lithium is not given as mood stabilizer in bipolar. That is completely false. Lithium is the gold standard mood stabilizer we use in bipolar. Bipolar, right? That is false. What are the other mood stabilizers we use? One is sodium valproate. Then lamotrigine is one. Carbamazepine also we use. But the gold standard first line is always lithium. Always lithium, right? Antidepressants increase the risk of mania. That's completely true. That's why we don't give uh, antidepressants alone in bipolar disorder. Right? We always combine an antidepressant with the mood stabilizer. We never give it alone because there's high chance of getting mania. Getting mania, right? So remember, very important. Antidepressants are never given alone in bipolar affective disorder. That is true. Okay, this question. Which of the following is true or false regarding alcohol? Alcohol. It is a source of empty calories. Empty calories. What is meant by empty calories? So empty calories means it gives you energy without adequate nutrients. Right? So there are calories, but there are no adequate nutrients like no vitamins, no proteins, no minerals. But it contains some amount